Here from Vet Triage. We are continuing on with this veterinary surgery journal from April 2022, and we are looking at canine TPLO, or rather orthopedic surgery, the osteotomy and tibial tuberosity transposition, and ex vivo mechanical study. So a few things to go over here. Angular deformities are not my strong suit. They get quite confusing, and the doctors who specialize in this, awesome. The angulation-based leveling osteotomy. So the center rotation of angulation is where if you have a leg, let's just say it's a crooked leg, it's got an abnormal angulation to it for whatever reason, whether they're born that way or whether it was trauma. You can measure how off the normal axis that bone is, and that's the center of rotation of angulation. That's the center by which the bone is off kilter. So leveling osteotomy, that's based on, make sure we're still recording. Okay, good. It's based on the center rotation of angulation, is a bone surgery that's trying to correct for that abnormal angulation of bone. And then tibial tuberosity transposition, the tibial tuberosity is the portion of the tibia right here. The transposition is when you make a cut into the tibia tuberosity, like so, and then you move this entire bone in whatever direction you need to try and align the patella, which is going to be up here. So that's what those words mean. And then ex vivo means that it's a cadaver study. It's outside the body. So, and this is by Dr. Tyler Clough, who I actually worked with at Las Vegas Specialty Center during his internship. So he's primary author. Well done, Doc. So this paper does come out of a specialty center in Ohio, another specialty center in Maryland, the College of Veterinary Medicine in Texas A&M, the Ohio State University as well. And Dr. Clough, again, was the primary author on this paper. So let's go through it. The objective of the paper is to describe a technique of combined center of rotation of angulation-based leveling osteotomy with tibial tuberosity transposition, and to compare the load to failure between the center of rotation of angulation-based leveling osteotomy combined with a tibial tuberosity transposition and that surgery, or a tibial tuberosity transposition alone. Ex vivo. There's a lot of abbreviations that they have in this paper. I'm going to try and not use abbreviations for the sake of the viewer, so bear with me, because it's going to be a bit slow. Method includes 6 pairs of cadaver tibia were tested in each group. So one group is the center of rotation of angulation-based leveling osteotomy with a tibial tuberosity transposition versus that osteotomy without a transposition, and this versus a tibial tuberosity transposition. The results show no difference in mean load to failure identified between the center of rotation of angulation-based leveling osteotomy with a tibial tuberosity transposition at 897 newtons and the osteotomy alone, which is 943 newtons. There was also no difference in the mean load to failure between the combined osteotomy with a tibial tuberosity transposition at 928 newtons and the tibial tuberosity transposition alone at 1,046 newtons. Therefore, they concluded that performing a tibial tuberosity transposition in combination with the osteotomy does not weaken the construct failure to load, and you could consider these surgeries as viable options for concurrent management of cranial cruciate ligament deficient stifle and medial patella luxation. So I have a video on this channel that talks about cranial cruciate ligament surgery. In fact, I have several videos on that, so feel free to search for those in my channel. And then medial patella luxation is when the patella, which is up here, it's the kneecap, moves in a medial direction. It moves outside the groove, and of course that predisposes them to arthritis and ligament tears. Introduction. The correction of medial patella luxation includes soft tissue reconstruction, trocheoplasty, distal femoral osteotomy or ostectomy, and lateral tibial tuberosity transposition. A recent study showed that the combination of a tibial plateau leveling osteotomy, which is the surgery we're showing here, the tibial plateau, which is this part here, gets leveled, so you make a cut into the bone like this, rotate this bone in that direction there. So you can see now it's offset. So you go from this shaped bone to this shape, then you place a bone plate and screws, and that levels the tibial plateau, which eliminates the need for the cranial cruciate ligament, which has been ruptured in this example. So a recent study showed that doing this surgery with a tibial tuberosity transposition for medial patella luxation had a 50% reduction of construct strength when compared to TPLO, that's this surgery in the picture, and tibial tuberosity transposition alone. The combining of TPLO with the transposition procedure requires that the transposition intersect with the TPLO osteotomy. That intersection, along with the loss of buttress effect of the proximal tibia metaphysis, may be the reason for the lowered construct stability. A recently developed surgical treatment option for cranial cruciate ligament disease involves making a proximal tibial osteotomy based at the center of rotation of angulation. By cranial rotation of the proximal segment, the center of rotation of angulation based leveling osteotomy aims to reduce the cranial tibial thrust of the stifle. This osteotomy has been performed in patients with excessive tibial plateau angles, as well as those with open physis. Physis is the growth plate, and dogs can have a growth plate here when they're young that makes orthopedic surgery more challenging, because if you ruin the growth plate, you can cause an angular deformity in their limbs. It is speculated that the cranial rotation of the proximal tibial segment with the osteotomy will allow maintenance of the buttress effect if a transposition is simultaneously performed. The can use anecdotally to treat cranial cruciate ligament rupture and medial patella luxation simultaneously in 2 dogs with good results. Materials and methods. These dogs were suspected to weigh between 20 and 35 kilograms. Group 1 is the osteotomy and the osteotomy with the transposition. And then group 2 is the transposition and then the osteotomy with transposition. And the osteotomy with transposition, they had a, desired postoperative tibial plateau angle of 10 degrees. So 0 to 10 degrees is what you're aiming for here. Most dogs have like 25, 26 degrees. Excessive is like 50 degrees. Angulation, which is abnormal. So you want to get it to between 0 and 10 degrees. That's your goal with the tibial plateau angulation. So that's what's cut here and leveling it out. And then here's a picture of all the surgeries. The radiographs are a bit fuzzy, but this is the intricacy of the procedure that they are performing in these cadavers. Regarding mechanical testing, the tibias were potted, secured rigidly to the base of a servo-hydraulic materials test frame at an angle of 135 degrees. This angle was chosen to mimic the mid-stance weight-bearing angle of the stifle in dogs. And here is the fairly gross construct there where they are testing it and the angulation at 135 degrees. Okay, the results in group osteotomy with tuberosity transposition group. The mean load to failure for the osteotomy was 943 newtons, and then the combination of osteotomy with tibial tuberosity transposition had 897 newtons, and they did not differ. Within the osteotomy specimens, the mode of failure where ligament avulsion from the insertion of the tibial crest ligament avulsion from the insertion of the tibial crest, compression screw track, and most cranial screw hole in the proximal tibia. Within the combination of osteotomy and tibial tuberosity transposition, modes of failure were ligament avulsion from the insertion of a tibial crest. They're talking about avulsion of this ligament here from where it attaches on the tibial crest. And tibial crest fracture, fracturing this tibial crest through the countersunk compression screw track and most cranial screw hole in the proximal tibia. And then for group 2, they had here, so group 2 again is the tibial tuberosity transposition and then the combination of osteotomy with tibial tuberosity transposition. The mean load to failure for the transposition group was 1,406 newtons. Then the combination group was 928 newtons. They were not different. With the tuberosity specimens, mode of failure were proximal, transverse, or oblique tibial fracture through the distal tension band hole, or they saw ligament avulsion from the tibial crest, or they saw tension band failure with breakage of orthopedic wire. Within the combination of osteotomy and tuberosity transposition group, the modes of failure were displacement of the translated tibial crest segment with untwisting of the orthopedic wire and pull out of the K wires. and then they also saw ligament avulsion from the insertion point of the tibial crest. All right, discussion. The findings here support the view that in a cadaver model, correcting two common pelvic limb orthopedic conditions, which is cranial cruciate ligament rupture and medial patellar luxation, is possible without losing construct stability when performing the osteotomy and the tuberosity transposition. The osteotomy differs from a TPLO in that the proximal tibial segment is rotated cranially rather than caudally. So here you're moving this segment caudally, but in the osteotomy here, you're moving it cranially. The fact that there was no difference in load to failure between osteotomy alone and osteotomy with tuberosity transposition is probably due to the maintenance of the buttress effect between the tibial plateau and the tibial crest. There is no fulcrum effect that is created, such as that which is seen with a TPLO when it's combined with a tibial tuberosity transposition. The load of failure for the transposition was not different to the osteotomy with the tuberosity transposition combination. In contrast, another study found the load to failure with transposition was higher than with a TPLO and a tibial tuberosity transposition. Within the tuberosity transposition, the goal was to leave the distal periosteal tissues intact, whereas with the osteotomy and tuberosity transposition combination, this was not possible. The quadriceps muscle force is about 94.8% of body weight, which is crazy, it's huge. However, the tension on the patellar ligament during running or jumping may be significantly higher, and that's why they're stressing at the mode to failure in these constructs. It's important to note that the patellar ligament detaches from the tibial crest. The specimens in our population that failed at lower than 400 newtons likely did not reflect how these constructs would perform in the actual animal. And that's it. That's the study. Fantastic work, doctor. Obviously, you want to have more limbs, and of course, to increase the numbers. But in an ex vivo study, probably doesn't matter as much. And of course, you'd also want to try these out in real dogs as well for future studies. So it's a good start. And yeah, thanks for supporting the channel, and we'll see you guys again tomorrow. Take care.